Welcome to the debut episode of Equal Dose, the podcast dedicated to exploring ways to improve health outcomes for us all. I'm your host, Autria Godfrey.
And I'm Stephen Horn. In each episode, we'll delve into the critical issues affecting our well-being and increasing health equity.
In our first episode, we are looking at a pressing issue that touches countless lives across the United States: access to mental health services. But first, we want to make this disclaimer. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions. All right, Stephen, over to you.
Thank you, Autria. So joining us today in our London studio is Laila Rizvi, Director of Strategy and Research at WebsEdge, the company behind this podcast. Laila will bring her passion for health equity to the discussion. Laila, welcome.
Thank you for having me. I'm happy to be here.
Great to see you on our first edition of the podcast, Equal Dose. What do you make of that, Laila?
I mean, I'm very grateful to be here.
It's exciting, isn't it? I'm joined by Autria all the way from Washington, D.C. Gosh.
That's right. It's a transatlantic effort here today. We are very excited for this very first episode. And, we're hoping to unpack the complex landscape of mental health services. So, Laila, what do we have coming up?
So we've got an interview with the renowned psychiatrist, Dr. Komrad, coming up, who's part of the psychiatric faculty at Johns Hopkins, LSU, the University of Tulane, and the University of Maryland. And he's on the scientific advisory board for the company Healthy Gamer.
In the US, patients with insurance coverage often face restrictions and limitations that inhibit access to behavioral health care. Insurance may limit treatment and only cover services they deem medically necessary.
So for a little bit of background and context here, the Mental Health Parity and Addiction Equity Act was a 2008 federal law that requires that insurance plans that cover mental health do so at the same level as physical health. Well, despite the law, insurers have often made it difficult, to say the least, for people to access in-network mental health care.
So NAMI, the National Alliance on Mental Illness, actually did an online survey of people with mental illness who had private healthcare insurance. And they found that the respondents were twice as likely to be denied by their private insurers mental health care compared to other medical care. And it shows that, these limitations placed by insurers foster a behavioral healthcare system, which is a crisis response behavioral healthcare system, as opposed to one which is anchored in prevention and maintenance.
So the big news coming out of the United States today is that the Biden administration is trying to do something. They announced a final rule on September 9th meant to expand access and lower costs for care for mental health and substance use disorders. Most provisions in the rule will apply to group health plans and health insurance issuers for plans starting January 1st or after. So under this rule, mental health and substance use disorder care on private insurance plans should be covered at the same levels as physical health benefits. Now, that may mean adding more mental health and substance use professionals to their networks or reducing the red tape for providers to deliver that care. All of this is according to the White House today.
President Joe Biden said in a statement, mental health care is health care, but for far too many Americans, critical care and treatments are out of reach. Today, my administration, he says, is taking action to address our nation's mental health crisis by ensuring mental health coverage will be covered at the same level as other health care for Americans.
Such a pleasure now to have Dr. Mark Komrad, Faculty of Psychiatry at Johns Hopkins, Tulane, LSU, and the University of Maryland, as well as the author of You Need Help, a step-by-step plan to convince a loved one to get counseling. Thanks so much for your time today, Dr. Komrad.
Well, thank you for inviting me.
Definitely. All right. It's a pretty big day for us to be talking about mental health because the Biden administration just announced a rule aimed at ensuring mental health care coverage for 175 million Americans is now on par with their physical health care coverage. First question to you. Do you welcome this? What do you think?
Well, of course I welcome this, and I'm very excited, although hopefully, they can walk the walk, not just talk the talk. The fact of the matter is that mental health coverage was established as a widespread availability for people back with the Affordable Care Act. However, many of those provisions have been realized more in the breach, and it's been problematic. Really, the exciting thing about this new announcement is what I call the 3 Ps. Prior authorization, parity, and programming. Really, some of the great inhibitions to accessing mental health care include the failure to observe parity, which was inherent in the Affordable Care Act, namely that psychiatric disorders and services should be covered at the same level as any kind of other medical services. So they're trying to put more teeth into a law that's already been there. Then another real interference with mental health care is something called prior authorization. Prior to actually approving getting outpatient treatment or inpatient treatment or many medications, that the doctor has to go through some considerable hoops arguing the case as to why this medicine is justified, this hospitalization is justified, and so forth. So trying to set limits on those kinds of hoops. And then finally, with regard to the program, this really refers to the networks that insurance companies provide. And one of the real unfortunate phenomena we see are ghost networks, namely when you sign up for an insurance and you see all of the various, particularly psychiatrists, mental health providers that are on the list. It turns out that many of those names are either people who retired or died or moved away or left the insurance program or were never in the insurance program to begin with. So that is also being very vigorously addressed with this new policy, which I hope will have teeth, not just strong recommendations, but consequences for not observing some of the changes they want.
Quick follow-up here. Do you think that it's comprehensive enough? Does this new rule go far enough? Is there enough coverage here? Or is there still more room for progress?
Right. There's absolutely more room for progress. I mean, there's a lot that it doesn't cover. We have to start somewhere. For example, the rate at which the insurance companies reimburse psychiatrists and the difficulty getting those reimbursements are one of the reasons why 51% of all psychiatrists do not take insurance, as opposed to other specialists who about 98% take insurance. And we're talking about not just taking private insurance, but also Medicare and Medicaid, because the levels of reimbursements are so very low because having to go through the hoops of prior authorizations, many things to discourage mental health professionals from participating. So none of that is being addressed in this particular policy aspiration.
So there is still room for growth. That kind of gets me into my next question. And when you look back on your extensive experience, how would you characterize the current state of mental health services, particularly when it comes to in terms of accessibility and equity? I mean, you just touched on it there, that if you're not taking insurance, that's requiring patients to pay out of pocket. And I would think that the line in the sand there of the haves and the have-nots would be pretty severe.
Right. And indeed it is. This is still America. It's still a country where you get what you pay for. And the fact is that what we often see is that the settings in which insurances are taken tend to be, not exclusively, but tend to be large clinics with large throughputs, with not a lot of time spent with treaters, particularly with psychiatrists who are mostly consultants to other mental health professionals that may have brief interactions with patients. But, the current state of mental health in many treatment and access to services in many ways is both better than it's been and in some ways worse than it's been. Telehealth, for example, it was really opened access considerably for people who used to have problems, getting places or in areas where there were not very many providers. 50% of all counties in the United States have 1 or 0 psychiatrists. 50%.
Mind-blowing.
So people can get access in more rural areas. And this is especially good for families that have children themselves who tend to be a lot more comfortable talking from their bedrooms on telehealth. So in those ways, that's better. And in many ways, it's helped to destigmatize treatment because of that easier accessibility. However, in order to do that, you have to have the technology for telehealth, which for some people, particularly the elderly, the best they can do is telephone. Having telehealth has made the demand much higher because it's so much easier to make appointments, and which is good, but it's also led to a proliferation of online treatment mills with very low thresholds for prescribing medications, for inadequate follow-up, not necessarily adequately trained providers. In fact, it's these kinds of mills that have contributed to the shortage of stimulant medications for ADHD. And now we have a 30% increase since COVID in the number of prescriptions for these kinds of medications. So, that's created a kind of glut. And then finally, I would mention in terms of the state of mental health, we have, a shortage. We have shortages of many things. We have shortage of hospital beds. We have shortages of trained practitioners. And so what we might be able to do is to extend accessibility by having mid-level practitioners available for people like nurse practitioners, physician's assistants, and so forth. However, the level of training is really a fraction for these mid-levels than it is for psychiatrists. And so we have more clinicians available, but not necessarily to meet all the demands, adequately trained and adequately supervised clinicians. So it's a really mixed bag.
Mark, it's Stephen here, sitting over in London. Hello, and welcome so much to our program. We really appreciate you taking the time to speak to us today. I mean, you're an ethicist, aren't you? So what are some of the major sort of ethical dilemmas you have faced and do indeed face?
So I would say, first of all, and much more commonly, is the ethical dilemmas of involuntary treatment. Right. Psychiatry is the only field of medicine that really is involved with overriding a patient's refusal for treatment under rare and specific circumstances. So one of the things that so often comes up is how do you thread the needle between preserving and maximizing people's civil rights and autonomy and self-determination, and on the other hand, your right to access state-of-the-art mental health care. So we see very often we get caught in that gap between, on the one hand, the right to self-determination, on the other hand, the right to get treatment and be well. And we have additional aspects that come into that. So we bring in the court with administrative law judges and so forth to try to help broker the conversation and apply guidelines and law. But that tends to be, very, very difficult. Now there's, in California, is really extending the criteria in a way that's unique here in the U.S., and that is they have now passed a law allowing substance abuse as a diagnosis that is potentially eligible. Heretofore, if you had only a substance abuse disorder, despite whatever dangers that may pose, you were not eligible for involuntary treatment, involuntary commitment. So now we're going to kind of glut the system with a whole new sector of patients. So other issues that have come up in my ethical travels and consultations, I think the one that I'm most involved with these days, and have really become one of the leading voices in this country to express my worries and concerns about, is physician-assisted suicide and medical euthanasia. Particularly as a psychiatrist, the whole idea of cooperating, participating, and even providing suicide for patients is really anathema to a psychiatrist. In many ways, this is kind of an unintended consequence of parity, right? Is we have been promoting the idea that psychiatric patients should be treated like any other patient in healthcare and have, this access to the same kinds of resources and services and coverage and so forth. So I've been very involved in making very extensive arguments, both in debates, in interviews, and also in a number of publications as to why I think that physicians, and especially psychiatrists, should prevent suicide, not provide it, and that this is neither good medical ethics nor good public policy.
I was at the APA this year, the annual conference in New York, and I did several interviews on this when I was in New York. And it was interesting to me that everybody I spoke to was very respectful and were trying to work their way around the issues that you were talking about. But there were some differences of opinion on this.
Oh, yes.
And if am I right that there are some states that allow this and some states that don't?
Well, we have 12 jurisdictions, that includes Washington, D.C., that permit physician-assisted suicide in the U.S., which, by the way, the definition of that is the doctor writes a prescription for lethal medications that the patient takes on their own at the time and place of their own choosing. Euthanasia is, by definition, where a physician starts an intravenous and pushes a lethal injection, just as in lethal executions. Those are two different approaches. In the United States, we have only physician-assisted suicide, whereas in Canada, Benelux, and some other countries, Spain, they have both. I do, worry, and there is some actually preliminary evidence that changing the balance between what's acceptable killing and unacceptable killing, and what's the kind of two tiers of suicide, the suicides we should prevent and the suicides we should provide, actually is problematic, may actually be invigorating the phenomenon of suicide contagion, and frankly removes the taboo.
Dr. Komrad, I'd like to now pivot onto Healthy Gamer, which is a company which Web's Edge have worked with, and how we've gotten to know you. Could you tell us a little bit more about the mission of Healthy Gamer and how it aims to support the gaming community, and particularly the younger generation?
Yes, indeed. First, let me just say that I have no ownership interest in Healthy Gamer. And I am not an investor in Healthy Gamer. I am on the scientific advisory board and have been asked to come both as a psychiatrist and as an ethicist to try to help them optimize their program and their ethics, and to make sure that things are really in a state-of-the-art way without getting into any sort of troubled problems, because this is really a new kind of pioneering effort. It all began with Dr. Kanoja, Dr. K, as he's called, appearing online. He is a very well-trained, Harvard-trained physician and psychiatrist who himself was a gamer, who himself actually talks about how earlier in his life he had what he felt was an addiction to gaming. And he started to broadcast on Twitch, which is the world's most widely watched online streaming platform for watching other people playing games. Kind of a viewership of many tens of millions of people. And he started actually a show in which he talked about psychiatry and mental health and so forth. And we're interviewing people and taking questions and so forth. And he really became a celebrity among the folks that watch Twitch, which are mostly younger people and mostly themselves gamers or gaming fans of video games. And that really attracted a great deal of trust and it was really a very positive way of portraying who we are and what we do as psychiatrists. Well, Dr. Kanoja, parlayed that opportunity into a set of services which are not traditional psychiatric services in terms of consultation and doctor-patient relationship and therapy and so forth, but really entered into the emerging world of coaching. Healthy Gamer it provides a service of coaching people online. They've served actually over 100,000 people at this point. It's really staggering. And it both does individual coaching support with people and group coaching. And those groups actually kind of create a little bit of a support community. And meanwhile, the organization is trying to establish national standards for what coaching training should be. National standards are only beginning to emerge very preliminarily as to what is coaching and where are the boundaries between what is coaching and what is treatment and therapy, which, by the way, is one of the missions of the Scientific Advisory Committee, is to help to discern and articulate what are those boundaries so that, everybody can kind of stay in their lane. And yet, coaching can also be a bridge. As coaches should be trained, and we try to train our coaches to understand when they may be getting in over their head and the problems that they're working on really need more highly trained professional help and more treatment. The other thing I want to say is that this organization provides tremendous educational tools about mental health. Dr. K has made a family of videos, really a remarkable collection of videos about various topics like what is anxiety, what is trauma, how do we understand depression, as well as some videos about techniques such as meditation. And they're available online. And now the organization is branching out into providing resources as well as even coaching support for parents who are worried about their kids, sometimes they're young adults even, in terms of how they are getting lost down the rabbit hole of gaming or the internet, social media, to try to create a balance between these kinds of activities as recreational, even social, even potentially healthful, and those that may start to become more, destructive and pathological. So, hence the term healthy gamer.
And could we ask you a little bit about your book, You Need Help, and some of the strategies that that you've discussed in there for helping families seeking help?
Right. So, this book emerged out of my radio show that I had that went coast to coast, where the most common question I was asked in this call-in radio talk show was, I have a mother, a brother, a cousin, a friend, a child who is clearly having more difficulty than I know what to do to help them with. Right. How do I convince them to see someone like you? And having answered that question scores of times on the air and brainstorming with people, I developed that as a specialty in my work, and after 20 years ended up writing this book about it. So the essence of what I discuss in the book is about empowering families to optimize their power. So the book starts with the most facilitative techniques about how to talk about these things, some do's and don'ts. It then goes on to talk about how we can partner with other influencers in the person's life, especially primary care physicians that may already have a relationship with the troubled person. And then if the techniques of persuasion and facilitated dialogue that I discuss are not working, and those influencers that have joined the team have not been sufficiently effective. But the fact of the matter is that families have power, and it may be necessary sometimes to consider what are the privileges that a family is providing a person that may need to be linked to that family members taking responsibility for getting their condition treated. So by closing some doors and opening some other doors, sometimes family privileges given with full intention of love and caring can end up becoming inadvertently enabling. So being able to look at how families might be inadvertently enabling the situations and begin to change the paradigm of providing privileges based on behaviors. And then finally, I educate people about, in the most extreme circumstances, how to mobilize the involuntary treatment systems that are available and to be able to step their way through those systems in order to optimize the opportunity, because there are certain places to show up and things to say and people to talk to that are important to know about. I've been involved in hundreds of cases and over the course of my 30-plus year career, particularly specializing in major mental illness and inpatient treatment for many of those years with involuntary treatment. So I've learned a lot of the ways the systems work and how to really navigate those systems in the most optimal way, which I try to share.
Thanks ever so much indeed for taking so much time to talk to us today. We really appreciate it, and huge thanks. So thank you.
Very fascinating interview with Dr. Komrad there. Well, that's all for today's show. Next time, we'll be talking about transplantations and donors, and we'll be joined by Christina Moon from the Billy Moon Foundation to talk about her husband's gift of life. Laila, what else is coming up?
So we'll be joined next by Luke Yates, who's a trustee of Live Life, Give Life. Luke's wife died while waiting for a transplant, and now Luke campaigns for others to register as donors.
And we'll also be speaking with Jeff Orlowski. He's the CEO of LifeShare Network in Oklahoma about encouraging donors from hard-to-reach communities and technological advances in organ donation. You're going to want to join us then.
So make sure that you like and subscribe everywhere that you get your podcasts. Until next time, goodbye.
Goodbye.
Bye.
Equal Dose is brought to you by WebsEdge.